Good evening.
Good evening, sir.
Yeah, who else is answering today?
Sir, I am answering, sir, and the other person I don't know, sir, who is answering.
Okay. Ajin will know.
Yes, sir.
Rakesh Yadav ji, make Mr. Abhishek Ghosh and make Mr. Nikhil Amir Chetty co-host. They both are answering. Gaurang Shah sir, we can't hear you.
Good evening, Dr. Gite.
Good evening, sir. Good evening, sir.
How is the scenario in our hospital, JJ?
काफी पॉजिटिविटी रेट है सर. डॉक्टर्स में भी और पेशेंट तो काफी पॉजिटिव आ रहे हैं. नियर अबाउट 30% डॉक्टर्स फ्रॉम ईच डिपार्टमेंट इज गेटिंग इम्पोर्टेंट.
But not very severe, है ना?
अपने पास भी एक रेसिडेंट, 2 फैकल्टी है, टोटल 3 पॉजिटिव है. स्टाफ में भी बहुत सारे लोग पॉजिटिव आए हैं, तो पॉजिटिविटी रेट बहुत है.
और स्टाफ
में भी पॉजिटिव आ रहे बहुत.
एंड रूटीन ओटी का अभी क्या सिचुएशन बोला है?
रूटीन ओटी फिलहाल मेजर सर्जरीज बंद की है, माइनर ओटी, इमरजेंसी, यूरेट्रिक स्टोन, ऑब्स्ट्रक्टिव यूरोपैथी, मैलिग्नेंसी, इतना सब चालू है।
ओके ओके, गुड इवनिंग पंकज।
गुड इवनिंग सर।
So we wait for another 4-5 minutes and then we start.
Okay, sir.
Today, na, Gite and Pankaj,
Sir.
we have got mainly one case, but then we will show another case also quickly. So not much of the history, mainly the investigation and the final management, because both are little different. The same, its pathology is same, but the two different cases. So if the time permits at the end for 10 minutes, we can have a discussion on that.
एक्चुअली मेरे पास भी था एक केस, भेजना भेजते भेजते मैं बीमार था तो उसकी वजह से नहीं भेज पाया।
No problem, but we can always
post to 5 o'clock।
हाँ, आपने जो किया था तो उसका अगर सब है तो अभी बोलो उसको, विवेक को, अगर तैयार है तो at the end we can make him co-host. We can just 5 minutes 10 minutes आप उसको सर बता दो। In that situation
नहीं हो, पिक्चर्स होंगे सर, पर लेकिन स्टोरी नहीं होगा, पिक्चर्स होंगे तो विवेक को बना के अगर पॉसिबल है तो भेजो बोल के बोल।
He can only present, na? He himself can just present for 5-10 minutes. So we have different scenarios today, and then we can just finish it. Because now we will not put much stress on history, because like pain in the loin region, there is not much of the, because we are discussing it since season 1. So all the students should know how to ask about history and present it.
Right.
Next time I talk to Ganesh and I talk to both of them, they said that we will have the complete overview about muscle invasive bladder cancer. So we have got Dr. Palak, who will be talking about the investigations in CA bladder. Okay, then we have got a Menon, who will talk about the pathology and the tumor markers. I will talk to Dr. Vasishtha Manyar, and Vasishtha Manyar will talk on chemotherapy, and Pal will talk on little, how to take the history and all. So let us see. Okay, so Abhishek, who are you and who else is the answer?
So Dr. Nikhil Amir Chetty from Madras Medical College.
Okay, fine. So I think we can start now. Huh?
Okay, sir.
Achin.
Yes, sir.
So Shetty, Amar, na?
Sir. Good evening.
Good evening, Amar.
So should I start?
Yeah, please start.
A Hindu gentleman, 22 years of age, resident of Mumbai, came with chief complaints of left flank pain since 3 months.
Okay. Just quickly, what are the positive and negative history will ask? Amar?
Sir, pain.
Abhishek has been answering since last 4-5 clinics. So we will ask him less questions and more questions to you. So you answer.
Okay. Sir, there is a pain on the left flank region for the last 3 months, sir. So what is the nature of the pain, sir? Is it dull aching pain or sharp, and how the pain has changed over the course of 3 months? We'll ask. And is it localized pain only, or and associated features, sir? Like, is there any fever or anything with the pain? That thing we would like to ask, sir. And anything that will decrease the pain, like associated with urination after passing, something like that, or if there is any blood, like hematuria is present, that we will ask, sir. And also like lithuria is there or not, associated LUTs are there or not for the patient. These things I would like to ask, sir.
Okay. Abhishek, anything else you want to add?
Sir, the nature of the pain, what kind of pain is, first of all, onset, duration, and progress of the pain? How did it start? Was it insidious? How is it progressing right now? It is progressive, or it has stopped, or it has come down? Any aggravating or relieving factors, sir? Especially with respect to passing urine, does it come down after passing urine or not? Does he have to take medications for that or not? And then, other than that, sir, any radiate? Does it radiate anywhere, sir? Radiation of that pain, and then thereafter, sir, associated factors, sir, is it associated with fever? Is it associated with any lump in the loin? Is it associated with nausea, vomiting, hematuria, dysuria? Sir, like that, I'd like to proceed.
Okay, fine. Achin, go ahead and finish the history.
The patient was apparently asymptomatic 3 months back when he started developing left loin pain, insidious in onset, gradually progressive, dull aching type, continuous in nature, relieved by medication, aggravated by moving around, non-radiating type, no positional variation.
Okay, go ahead.
No issue of nausea, vomiting, no issue of fever or burning urination, no issue of lithuria or hematuria, no issue of trauma, no issue of previous similar complaints, no issue of any LUTs, no issue of facial puffiness, lower limb edema, or exertional dyspnea.
Fine. Amit, anything else you want to ask apart from that? Hello?
Hello?
Yeah. You want to ask anything else?
Nothing much, sir. Everything is given here. The pain, only pain is a complaint, sir.
And, yeah. Dr. Gite, Dr. Maheshwari, at the end, we will give them the scoring personally, that how they have fared. They have fared very good, good, or average. So let us finish it, like in exam, you are not given more than 30 to 40 case presentation and question answer in 40-45 minutes. So that remaining thing, we have got time for other discussion. Correct?
Sure. Okay.
Yeah. Okay. Fine. Go ahead.
So past history, no issue.
Maheshwari, you want to add them? Anything else they have forgotten and not asked?
No, I think it's covered quite well, sir.
Okay. Is there any suggestion about any, during neonatal or during pregnancy, anything to be asked regarding that?
Any growth retardation during pregnancy, any failure to thrive, any yes, sir, any birth problems during childbirth, whether he had or not, any history of infections in the immediate postnatal period, sir, that I would like to ask, sir.
Antenatal events also I would like to ask, sir. During antenatal scans, was anything found? And
yes.
Was a delivery, things, sir, a premature delivery or a normal full-term delivery? This I would like to know, sir.
Dr. Gite, what should be the age group till that time you should ask about the antenatal history?
Sir, as everyone knows the diagnosis, today's case is PUJ.
Yeah.
So it is either incidental or symptomatic or antenatally diagnosed. These are the three ways anyone can diagnose the PUJ. So incidental, it can sonography to be done for something else, and sonography suggests of bilateral hydronephrosis in lateral hydronephrosis with hydropele. Antenatal history should be asked each and every patient, because uh, that antenatal hydronephrosis may go silent and detected incidentally in later phase of life. So antenatal history, if you are suspecting a PUJ,
Yeah.
should be
I think till the young age, till the young age, unless and until the patient is older, then it's okay. Till the young age, they should ask about the antenatal history.
As far as the
Right?
children is concerned, usually they present with UTI, flank mass, flank pain, hematuria. In adult, it is usually flank pain, UTI, aggregated by including hypertension, sometimes abdominal masses. Sorry. So 35% of the patients are diagnosed with having a history of recurrent UTIs, and 25% of the patients are diagnosed with a history of hematuria. Then near about 50% cases had a history of antenatal hydronephrosis. And in antenatal hydronephrosis also, you have to ask, it is vaginal delivery, it is LSCS, premature, complete, and also a history of oligohydramnios. And antenatal diagnosis management is a different chapter we discuss later on. So ये पूरा पूछना पड़ेगा सर, और एंटीनेटल अगर अभी बताना है तो मैं
correct.
एंटीनेटल बताना है तो मैं
history is very important.
क्या एंटीनेटल हिस्ट्री is very, if you are suspecting PUJ, ask PUJ related symptoms, ask PUJ complicated related symptoms, ask associated PUJ associated diseases like vascular reflux, multicystic dysplastic kidney, sometimes esophageal atresia, sometimes congenital heart diseases, and then sometimes imperforated anus. These are the associated other anomalies. So if the child is in front of you in the OP, then you have to see all these things also. So it is depend upon the age. We have to ask the history and check for the findings inside that particular patient.
Yeah. Okay. So Achin, go ahead.
Yes, sir. Past history, no issue of any diabetes, blood, hypertension, ischemic heart disease, no history of any previous surgeries, and there is no significant antenatal history a patient can elaborate on. Family history, nothing contributory. Personal history, diet is vegetarian, appetite is adequate, bowel bladder is regular, sleep is undisturbed, habits non-smoker, non-tobacco chewer, and non-alcoholic.
Fine. So Abhishek, now next what?
Sir, examination of the patient, sir.
Important thing you just tell us. Then we will show you.
Yes, sir. Examination of the patient, sir, on inspection, apart from the overall examination of the
general
abdomen.
Examination, you will like to?
General examination,
General
sir.
examination.
Yes, sir. Sir, in general examination, I would want to find out about whether the patient has hypertension or not, other than the other general examination findings. And then I would like to proceed to the local abdominal examination and systemic examination, sir.
Okay. Bye. Just show him. What are the findings?
Sir, the patient.
Can you show that?
We don't have any picture of this. Is the adult male, sir.
The one which I... Okay. Fine.
And there is no, in this patient, there is no mass like, sir. All examination is normal. Umbilical centrally placed. All quadrants move equally with respiration. No scars, sinuses, and gauge veins. No local rise of temperature tenderness. Bladder not palpable. Tympanic node present all over the abdomen. Normal liver dullness span. Normal bowel sounds present. And other system examination is also normal, sir.
Okay. Fine. Yeah. Tell me, Abhishek. Next what?
Sir, examination of genitalia. I want to do, sir.
Genital examination is grossly normal. Meatus is normal. Patient is non-circumcised. Bilateral testes are normal.
Okay. Sir, so then after this, I would want to evaluate the patient, sir. I'd want to do some routine blood investigations, including CBC, renal function test with emphasis on serum creatinine, urine routine microscopy, and an ultrasound KUB, sir.
Fine. You showing.
The investigation shows hemoglobin is 15.4, count is 6,000, creatinine is 0.8, sir. And urine routine micro shows RBC is 12 to 15 per high per field, pus is 30 to 40 per high per field. Culture sensitivity shows no growth, sir.
Okay. Nikhil, anything else? Nikhil, can you hear us?
Sir, yes, sir. Yes, sir. I can hear. Sir, here there are RBCs, sir, and there are pustules also, and creatinine and everything is normal, sir. I would like to see the ultrasound, sir. Ultrasound KU.
He told very specifically there pustules are there.
Yes, sir.
Culture is sterile.
Culture is sterile, sir. And pustules are also present, sir. So ESR also we can. I would like to know whether ESR is done, sir, for the patient. ESR and testic, sir.
ESR.
Okay.
Yes.
Why?
Ultrasonography.
Why ESR?
Sir, this can be testing, sir. In GUTV also we can get a sterile culture.
How specific is ESR to diagnose the GUTB?
Sir, it's not very specific, sir. It's non-specific.
So if you are suspecting a sterile pyuria, you must know the causes of sterile pyuria. That is one.
Yes.
Another thing, if you are suspecting a tuberculosis, which is the best way to get rid of the diagnosis, is there or not?
Yes,
It
sir.
is not. It is definitely not by doing this.
Yes, sir. Yes, sir. It is not in any of the criteria, major, minor.
So if you want to get rid of the tuberculosis, there or not, which investigation you want to do?
Gene expert.
Tell me a single investigation.
Gene expert.
Yes, that's all. Either it will come as a positive or it will come as a negative. At least that particular point, that particular diagnosis get rolled up.
Yes.
Okay. Sonography. What
Okay,
are the things?
Achin.
Sir, sonography film is not available. A handwritten report is there, sir.
No, don't say report. What are the things you are expected on sonography in the case of UJ in a antenatal as well as in a adult or postnatal? So you start with antenatal. So what are the things you want to see? Because here there is nothing practical to be discussed except pyeloplasty. So the theory can be discussed. So antenatal diagnosis using the sonography.
Sir.
So tell me, what are the things you want to see?
Antenatal diagnosis, there are different grading systems that have been used, sir, for classifying this antenatal hydronephrosis. So now the recent one is UTD, sir, that is upper tract disease, and the even more advanced is ONN. But whatever it is,
what?
Yes, sir. What we see is, sir, we see the dilatation that I want to see, sir. One is the calyceal dilatation I want to see, whether it is central or peripheral calyceal dilatation. Second one is the cortical thickness I want to see, sir. How much is the cortical thickness? And these SFU or these things, SFU does not classify the lower ones, sir. But I also want to see whether the ureter is dilated or not, whether the bladder is dilated or not. What is the bladder wall thickness also I want to see.
It start from the prostatic urethra or it start from the parenchyma.
Yes, sir.
So cortical thickness, minor calyceal dilation, major calyceal dilation. What is anteroposterior diameter of the pelvis?
Correct.
What is the size of the kidney? And what are the then is there any associated hydroureter or not? Then this bladder is distended, bladder is empty.
Yes.
Then thickness of the bladder wall. Then is there any keyhole sign or dilated posterior urethra? Then associated oligohydramnios, associated polyhydramnios.
Yes.
So these are the things from top to bottom you have to see in antenatal sonography. And there are grading systems. SFU grading, if you know, tell me SFU grading.
Yeah.
Tell us the grading.
SFU grading is 5. Yes, sir. Sir, grade 1 is normal, sir. And grade 2 is this thing, central dilatation is there, sir, for grade 2, that is mild dilatation. And grade 3 is central and major calyceal dilatation, sir. Grade 4 is major and minor calyceal dilatation, sir. And grade 5 is parenchymal thickness. The parenchyma becomes thinned out along with the dilatation.
Okay, what about the size of the pelvis? What is the grading?
Sir, size of the pelvis is in...
Three things are considered in that SFU dilatation, SFU grading. One is anteroposterior diameter.
Sir.
Another is calyceal dilatation. Another is pelvic dilatation.
Yes, sir.
Okay. So
Yes.
mild pelvic dilatation with mild renal, mild minor calyceal dilatation with anteroposterior diameter less than 10 is grade 1. Mild renal pelvic dilatation, anteroposterior diameter 10 to 15, grade 2.
Okay.
Moderate pelvic dilatation with uniformly dilated calyces, grade 3. Uniformly dilated calyces with parenchymal thinning is grade 4. So this is based on the anteroposterior diameter as well as the parenchymal thinning as well as the calyceal involvement. Okay.
Yes.
So what are the causes of antenatal hydronephrosis?
So the most common cause is transient dilatation. Is the most common cause. Around 40 to 80% is transient dilatation only. And the other causes can be because of PUGS, or it can be because of PUR. It can be because of posterior urethral valve.
So in spite of telling like that, tell like this: obstructive causes, non-obstructive causes.
Non-obstructive.
The obstructive causes. So we start from the PUJ.
Yes.
So if it is PUJ, then UVJ, ureteric wall, multicystic dysplastic kidney, causes of dilatation. Ureter duplicated system, posterior wall, ectopic ureter, urethral atresia, acrococcygeal teratoma, or hydrohematocolpus. These are the obstructive causes.
Yes.
Then non-obstructive causes. Because question is why the dilatation resolve? So, the pure dilatation may be due to non-obstructive causes. That like vesicular reflux, physiological, as you told, it is very common.
Yes.
And then renal cystic disease or megacolicosis or hydrocolicosis. These are the non-obstructive causes of pelvic system dilatation. So if same antenatal hydronephrosis, so what are the prognostic criteria or indicators in diagnosis of antenatal hydronephrosis?
Sir, it depends on...
I will finish this in 10 minutes. Just but tell. Prognostic indicators of antenatal hydronephrosis.
Sir, one is a dilatation anteroposterior diameter, sir, whether it is less than 15 or more than 15.
Listen carefully. Prognostic indicators of antenatal hydronephrosis.
So which are the prognostic indicators?
Diagnosis, age of diagnosis. Important prognostic indicator is age of diagnosis. If gestational age is less than 24 weeks, associated severe oligohydramnios. What is oligohydramnios? Poor production of the urine.
Yes.
Okay. If the poor production of urine ultimately end up into the poor development of lung. And usually kidneys are bright or like a medical renal disease. So bright kidney, gestational age less than 24 weeks, and oligohydramnios. These are the prognostic indicator in the antenatal hydronephrosis. Same patient when got delivered, so how will you proceed?
Sir, same patient delivered after 48 hours. Minimum wait is up to 48 hours, sir, for doing the first scan.
Why?
That we have to do.
There is a reason.
Yes, sir. Because there is maternal...
48 hour oliguria.
Yes, sir.
2 to 10 days polyuria. So first 48 hours if you do sonography, it will look like normal. If after 48 hours you will do sonography, it will look like a hydronephrosis. So first 48 hours if you are planning for sonography, you have to repeat it after near about 10 days. So ideal way of doing a sonography post-operatively is after 48 hours and after 4 to 6 weeks. Okay.
Yes.
Suppose. Then same there is a hydronephrosis. Okay. On unilateral hydronephrosis with hydroureter, or in one case and there is no hydroureter in another case. How will you proceed? Sorry.
Unilateral hydronephrosis can be because of this thing, sir. We use a stricture or VUR that could be present sir, for the patient. Unilateral.
Hydronephrosis. Only hydronephrosis means it is only hydronephrosis on sonography ruled out vasoaccurity reflux. Technically, no.
No.
So still patient may have vasoaccurity reflux. So investigating for vasoaccurity reflux and each and every, there are two ways of thinking. Few people will say, yes, all patients should undergo voiding cystotomy. Few people will say, no, there is only a 10 to 14% patient associated with VUR in case of the PUJ. And in that particular 14% patient, if they are symptomatic like poor steam, lower nerve tract symptoms and recurrent UTIs, then only investigate like by doing the voiding cystotomy. So voiding cystotomy come karna ki nahi karna, it is depend upon the thinking of exam and your protocol at your.
Okay.
So if it is only associated with the hydronephrosis, now the baby is delivered. Now patient had after 48 hours hydronephrosis, then after 6 weeks again hydronephrosis. So here the question is early intervention and delayed intervention. So when you are neonatal pyeloplasty is in the infant, pyeloplasty is in the childhood, and pyeloplasty is in the adult. So there are indications. If in spite of severe hydronephrosis, parenchymal thinning, derangement of the renal function, in early phase of the life, one can go for neonatal oblique in neonatal pyeloplasty or pyeloplasty as early as possible.
Yes.
So diagnosis, confirmation in case of the child. In case of the child and in case of the adult, the ways of diagnosis is again different. In case of the child, only sonography and whatever the scan at that particular age. If it is immature kidney, MAC3 scan. If it is childhood, DTP can be done, EC can be done. So we will discuss later on what are the ways of doing the assessment of the renal function. So that particular two things can be sufficient in diagnosing the POJ in case of the pediatric age group, and in adult, definitely initially with IVP, nowadays with CTIVP. Okay.
So Abhishek, in child, in neonates, when you will do creatinine in liver?
Sir, after 48 hours.
Why?
Sir, because in the initial 48, before if we do, sir, it will come false, sir, because that time there is, yes, sir, because that time there is oliguria, sir. So creat may come as falsely high, sir.
So it is creatinine clearance is done by the maternal blood, na?
Maternal.
Yes, sir.
So that is why you should do it after 48 hours.
48 hours.
Then you will get the true report. Fine?
Right.
Okay.
Etiopathogenesis of the PUJ. So it is either congenital or it is acquired. In congenital, again it is intrinsic cause or extrinsic cause. So what are the causes, intrinsic causes? Bolo.
Loss of spiral musculature, dynamic segment.
Dynamic segment, loss of spiral, Osling folds are there, sir.
Okay, Abhishek,
so
you
most
answer.
common is adynamic.
Dynamic segment.
So what is meant by adynamic segment?
Sir, it is aperistaltic.
The ureter has longitudinal muscle, ureter has circular muscle.
Circular, yes.
Both.
Yes.
When there is deficient circular muscle in that particular segment, the segment is patent. Usually, when majority times you will see ureteric catheter run inside visually right up to the kidney, but still there is a, when you are doing the RGP, there is a narrowing. So the patency is there. Patency is there, but there is a deficient circular muscle. So it is a poorly distensible, narrowing, deficient of smooth muscle, which is patent. It is a pathological basis behind the aerodynamic segment. So extrinsic causes is again mechanical causes, adhesions, bands, kinks, or lower polar vessel or aberrant vessel. Okay. Then
yes.
intraluminal causes. Congenital structure, very rare. Ureteric wall, very rare. Benign fibroepithelial polyp, very rare. But for the completion of the cause is pathogenesis, again the intraluminal cause. So these are the causes. So now we come back to the case hour. So how will you proceed? So this is just theory related to the antenatal hydronephrosis. How will you assess the antenatal hydronephrosis? One thing I have forgotten, antenatal intervention. If you are so vesico-amniotic stent is an antenatal intervention done in a case where there is a severe oligohydramnios with bad prognostic indicators. Okay, in such situation, we have to go for the vesico-amniotic stent antenatal intervention. So come back to the case. How will you proceed?
Yeah. So sonography, we have discussed what to see. Achin, show the sonography.
Yes, sir. Sonography film is not there. Report is there, sir. Moderate to gross hydronephrosis is noted with maximum AP diameter 1.6 centimeter, left-sided. The right side is normal, sir.
Okay. So now Abhishek, next what?
Sir, next I would further characterize this by doing a triple phase contrast CT of the KUB region, sir.
Achin? Make Dr. Ganesh Bakshi.
Okay, so sonography, what more information you want to ask? I already told you. What are the things?
Cortical thickness.
You have
cortical
to ask.
thickness.
Yes, sir.
Cortical thickness has not been mentioned.
Size of kidney, cortical thickness, then ureter, whether it is visualized or not, then the status of the pelvic calyceal system. Other than that, parenchymal thickening, of course, parenchymal thickness. All this I would want to ask on USG. And of course, bladder wall thickening, if it is there or not. The status of the ureter, whether any hydroureter is present or not, and up to the prostatic urethra. Yes, sir.
So Dr. Gite told you, either you come from parenchyma and go up to posterior urethra, or you start from posterior urethra and come to renal parenchyma. So you don't miss anything.
Yes.
Fine. Okay. Achin, go ahead.
The CT scan is above.
Yeah, just see it properly.
If you want me to zoom, I can zoom.
Yeah, zoom it. Just zoom.
Sir, this is a contrast enhanced CT scan of the KUB, sir, which is in the nephrogram phase, sir. So right side of the kidney looks normal, sir, with normal contrast uptake by the kidney, and excretory system also doesn't look dilated, sir. And the left side of the kidney looks dilated, sir, with there's hydronephrosis present there, but the cortical thickness looks okay, sir, to me, except for one cut, the other of the kidney looks normal, sir. And the dilatation, there is a abrupt cutoff of the dilatation. Sir, can you go below? So show me the below cut.
You want to see what?
Below. Go up, go up. Yeah. So the ureter, I want to trace it.
So the Nikhil, what is your purpose of doing the CT scan?
The CT scan, this thing for the cortical uptake we want to see, sir. But DMS, DTP also will give the same.
So my purpose of doing the CT scan is
so for
functional evaluation.
Yes.
Drainage evaluation.
Yes.
Anatomical roadmap.
Yes.
And vascular evaluation.
Yes, sir. Vascular. Any crossing vessel.
So these are the 4 purposes for which I am doing the CT scan.
Yes.
Which is each and every question will not be answered in case of the IVP. So nowadays people are going for CT IVP. Okay.
Yes.
So see that all four features. But बाकी rest all the things sonography में दिखता है उसको confirm करना. Size of the kidney, cortical thickness, callus dilatation, major, minor, pelvic dilatation, aberrant vessel. उसके बाद में फिर ureter is seen, ureter is not seen, particularly in prawn film usually ureter is seen. Then contrast is reaching up to the bladder or not, or there is complete cut off. ये सब चीजें ये one go में तुमको बताने को आना चाहिए.
So now see the last fin and tell us about a kidney and ureter. अच्छा थोड़ा नीचे का फिल्म को थोड़ा enlarge करके दिखा दे उसको. The bottom line. Yeah. Okay, now this is a thing. Just final, you tell us what you see on the left side. Right side is normal. So what you see on the left side?
Sir, on the left side, the pelvis looks dilated, sir. External pelvis only, sir. It is.
No, say properly.
Sir,
again,
pelvis
either go from periphery to ureter or come from ureter to cortex.
Okay. So from outside, the cortical, there is some amount of cortical thickness thinning present, sir, and but the contrast uptake is there, sir, in the cortex, and the pelvis looks dilated, sir. Balloon out pelvis, and it looks like an extrarenal pelvis to me. And there is abrupt cutoff, sir, of the pelvis to the ureter. And the ureter is traceable down, and it is reaching up to the bladder, sir. So there is no dilatation of the ureter, sir, and only the pelvis is dilated. And
what about the calyx? What about the minor calyx? What about the major calyx?
There is dilatation, sir. There is a major minor calyxal dilatation seen.
What about the blunting? They are convex, concave.
They're convex, sir. There is a calyceal blunting, sir.
Blunting.
Calyceal blunting can be noted, and moreover, sir, the ureter is in dependent position, sir, in spite of so much dilatation.
Yes.
Okay. Why you are saying like that, Abhishek?
Sir?
Why?
Sir, it will help me with my management, sir.
Like?
Sir, I can, it's a large pelvis, sir. I can go ahead and it's a large pelvis and the ureter is in dependent position. So I can go ahead and do a dismembered pyeloplasty in this case, sir.
So in this condition, it will be a large pelvis.
Dismembered or
ureter will be highly.
Abhishek
or maybe a flap pyeloplasty.
Both.
Yes, sir.
The type of pyeloplasty is depend upon the configuration and size of the pelvis. Okay, and type of the pelvis.
Yes, sir.
If it is totally intrarenal, some different thing we have to. If it is totally intrarenal and external, then external but globular, external with dependent PUJ, external with high PUJ. So there are different indications for different type of pyeloplasty. If you know the findings of IVP, nowadays no one is teaching the IVP, then you can diagnose the same findings in CT IVP also. Like finding related to the callus dilatation. Contrast in this picture also, there is a accumulation of contrast in the dependent part, that is called as puddle sign, lacunae, crescent, then cell sign, rim sign. There are a number of signs related to the parenchyma, related to the callus, related to the ureter. If anyone want to ask in exam, they can ask, because conventional IVP and CT IVP is one and same as far as the luminal findings are concerned. So you know all these things. You should know. Examiner asks, and at least you have to know what is like. Usually sometimes your teacher, it is just rim बच गया, कुछ बचा नहीं, खत्म हो गया, CT पे बोल देता है, नहीं किडनी खत्म हो गया, just rim ही बच दिख रहा है. तो ऐसे सिचुएशन में ये indirect way of assessing the function. तो ये साइंस भी आपको अगर नहीं पता है तो पढ़ लेना, क्योंकि 6-7 साइन है, जैसे लैकुनी है, क्रिसेंट साइन है, पडल साइन है, रिम साइन है, सेल साइन है. उसके बाद में और एक एग्जैक्टली याद नहीं आ रहा, लेकिन ऐसे पूरे साइंस एक बार याद कर दो, क्योंकि दिस कैन बी सीन इन द CT IVP.
Nikhil knows about a sign. If you know,
No,
then
anybody
just,
knows, he can tell. No problem. I'm just
Abhishek or Nikhil, if you know, then go ahead. Otherwise, we'll go ahead with the case.
okay.
No, sir, not very sure.
No, sir, no,
Okay.
not aware.
Yeah. Fine. So now this is a case. Now next, what you want? So what is written? Stricture in left upper ureter as described, causing back pressure changes in form of hydronephrosis and hydroureter as described.
I'll play also, sir.
Yeah. Next,
Yes,
what you want to do?
right, sir. Sir, there appears to be, sir, there is a parenchymal thinning also, sir. I would like to assess the function of the kidney, sir.
ATPS.
So you want to only the function of the kidney or something else?
Function and
Function
the
and also
Rowley
the
curves also I want to see.
anatomical roadmap, sir, because
Yes, sir.
it says that stricture is there in the left upper ureter and there is abrupt cutoff also, sir. So,
No. What the next investigation you want to do?
a diuretic renography, sir, and an RGP, sir.
So renography will show you what you want to do for only for a function. In this case, you are seeing that this kidney is functioning. So you are going to save it, huh?
Yes,
If
sir.
you don't do
Yes,
renogram,
yes, sir.
you are
Yes,
going to save this kidney.
yes, yes, sir.
So now you want to do renogram for what?
Yes, sir.
So why do you want to do
It is
renogram?
excreting it.
Dekho, purpose of what sir is asking. Why want to do renogram? The purpose of doing
Sir,
renogram
differential.
is
Sir,
confirmation.
yes, sir, one is for
You tell
documentation.
me, if you are asking the exam, why you want to do renogram? What are the reasons?
Sir, one is to document the function of this thing, sir. What is the function of the kidney before operation? We want to document, and after surgery also it will help us in this thing, the documentation of how much is the function before doing the surgery and how much improvement, because we don't see improvement much, but whatever is there that will be static, so that can be explained to the patient. Second thing is that it will also give us about the differential function, and third thing is that orally curves are important, sir. That which case can we intervene, which case can be observed, because the second is the clear cut obstruction is there, and then you can go for it, sir. So these things will get, sir.
So it is baseline renal function 1.
Yes.
Another 2 is assessment of the obstruction is there or not.
Yes, sir.
Differential renal function.
Yes.
And quantification of the glomerular filtration rate or GFR.
Yes.
So which scan you want to do in which situation? Next question.
Yes, sir. If in this situation, I want to do a DTPS scan, sir.
Okay. Any other scan which is equivalent to DTPA?
MAC3
which will answer all questions. Because here your purpose is to diagnose the obstruction as well as to assess the function. So you have two questions in your mind, and that scan should answer that 2 questions.
Yes.
So which scan you want? Can only EC scan is okay?
EC scan also is EC scan and ETV, I'm sure that, but MAC3 is not available in India. That we don't do. But MAC3 will not be available.
So DTPA, EC, OIH is okay for this particular situation.
OIH
as well as
EDTA scan can also be done, sir. It is not.
Yeah.
Yes, sir.
Commonly done scan is DTPA, MAC3, DMSA, and these are 3 commonly done scans, and EC nowadays. So if you want to assess the differential renal function, it can be assessed by all 3.
Yes,
but if you want to assess the GFR, the best is DTP.
DTP, yes.
Because 95% is by the glomerular filtration.
Yes.
And DMSA is best for morphology.
Yes.
Correct. Yes.
Tubular secretion 95% in case of the MAC3. So again, MAC3 for the maturity of the kidney as well as for the assessment of the function.
Yes.
So what is important in last Pankaj sir told relative function is best assessed by DMSA. Yes, relative function can be best assessed by DMSA, DTPA, and MAC3 also. But here the finding on which you have to decide the planning or type of surgery is GFR. GFR is more important than the differential renal function. Because differential renal function, one side 70, other side 30. One side again 40, 60. So total is 100. They will match the two things and calculate. But GFR is very important. So how you are planning? So the purpose of doing the scan is baseline function. Then post-operatively, you can compare this with the preoperative scans, medico-legal purposes.
Yes.
Then third is assessment of the obstruction, assessment of the differential renal function, assessment of the GF. Okay.
Yes.
So this is the purpose behind doing the renal scan. Yeah, sir?
Yeah, sure.
पढ़ सकते हो तो पढ़ो.
Yes. So the pictures.
So
there is
sir,
right side there is a pooling of contrast scenes, and left side the prompt excretion is seen. Uptake is good sir in both of them. In the vascular phase, both of them are taking up good uptake, sir. And here in the excretory films, I think excretory. Is it the excretory films that we are seeing here with the corrective system analysis? That's a perfusion phase, not the perfusion phase, sir. I want to see the excretory correcting phase.
The lower graph is the uptake phase, uptake plus excretion phase, I feel.
No, it's an uptake phase only because uptake is normal. The excretory phase we want to see, and diuretic T-half also. And this one X11 and GFR, the differential GFR also. So this is an uptake phase. In the excretory only, we can comment about the orally person this thing excretory.
There is no separate image
The
available.
lower end is the excretory also, na?
Excretory, uptake plus excretory is the lower graph, the perfusion is the upper graph, and there are two sets of images. The upper set of images is taken for 1 minute, 2 seconds per frame. And the lower set of images are taken for 29 minutes. Conventionally, 30-minute scan is done, and 29 minutes, and they're taken at 15 seconds. So there is a total of approximately 150 frames. So in the uptake and perfusion phase, we can see a photopenic area also on the left side, which is correlating with the left-sided hydronephrosis that we can see. Plus the uptake is also low, sir. Excretion, and there is in the excretory phase there is retention of radiotracer in the left side, sir, which is suggestive of hydronephrosis plus that is pooling of contrast, and of course an obstruction. Yes, sir.
So when is this phase taken, sir? F0 or F minus?
Diuretic, sir. Diuretic, I can't.
In spite of contrast, better use term radionuclide.
Okay.
Yes.
Okay, sir.
There is pooling of.
These are the radionuclide.
Yes, sir. And region of interest is correctly only given by
the side two films are the overlapped films with the region of interest marked on them, sir. So in this, sir, I'm presuming the line in the the uptake phase, the blue line that can be seen is, I think, sir, the diuretic. So this should be F+10 protocol that is being followed.
Yeah.
Again,
already had nephrotic kidney.
Nikhil, question here is why this F10, F minus 15, plus 15, plus 20, minus 20, 0? Why this protocol?
This is a
one time दोनों एक साथ दे देंगे, क्या फर्क?
नहीं, स्पूरियस आएगा ना सर. लाइक अगर ऑलरेडी हाइड्रोनेफ्रोटिक किडनी है, मतलब कुछ कंडीशन में ऐसे है कि जैसे रिफ्लेक्स है, तो उनमें बेटर है कि आप कैथेटर डाल के फिर पेशेंट को वो स्कैन कर सकते हैं. नहीं तो रिफ्लेक्स की वजह से जो ऑलरेडी कूलिंग है उसमें आप कॉन्ट्रास्ट भी दे रहे हो तो स्पूरियस वैल्यू आ जाएगा वो. तो इसके लिए, और यहाँ पे जो ऑलरेडी हाइड्रोनेफ्रोटिक किडनी है तो इसमें F10 देने से मतलब कॉन्ट्रास्ट का भी आ रहा है उसमें और यूरिन भी है.
you are describing a different situation, doing a DTPA with PCN in situ, doing a DTPA with distended bladder, doing a DTPA with parietal catheter with empty bladder. So these are the different indications. The question here is, what question I have asked? Why the protocol? So by giving the plastic either pre, along, or after, we are creating the obstruction. So you are creating the physiologically. Suppose patient had a gross hydronephrosis.
Yeah.
The patient had a big hydropelvis.
Yes.
So if you are given a radionuclide, and it will take some time and it stays there only.
Yes.
So clearance will be delayed.
Yes.
As there is a gross hydronephrosis. If you want to see the real picture, then use minus protocol.
Minus.
In such situation, if you use a minus protocol, the plastic will
empty the hydronephrotic
create
kidney.
a more urine and it will empty the
Hydronephrotic kidney.
hydronephrotic kidney. And the exact is there obstruction is there or not can be asked. So
in the Campbell, it is given that 12 to 15 minutes is the time taken for Lasix to peak. That is why this came minus 15 plus 15 and all that.
Yes.
So that is the half-life of furosemide. And
yes.
when it is a grossly hydronephrotic kidney, or you're suspecting details crisis, then F minus 15 works by increasing the load in 15 minutes. That is why the Lasix is given 15 minutes before.
OMSI sign, sir. So OMSI sign basically is that only, sir. It is actually confirmed by F minus 15 protocol.
Correct.
Fine.
Another thing is, if you are done a DTP scan prior and it is suggested of suppose gross hydronephrosis with 40%. Yeah, 40 GFR.
Okay.
After doing the pyeloplasty, is all patient improved? The answer is no. Which patient improved? So it is depend upon the age of the patient and time of the patient. Which patient will deteriorate? Whatever the background activity counted in the while doing the DTPA as a hydronephrosis, that will get reduced. And patient will come to पहले तो 40% था, अभी तो 30% हो गए. So you should be very careful in telling the patient pre-operative.
Yes.
Yeah. Okay. Achin, go ahead. Show. Only one thing I want to tell you. Just previous slide. Achin.
Yes.
See on the top right hand side, what are the things written? That is most important. Yeah. Just read it. Then everything is clear.
So as a
diuretic dose, diuretic time.
Yeah. And they have mentioned that testing.
Sir, basically, sir, our focus should be on the radionuclide that is being used. Sir, the T half, the dose of diuretic 40 milligrams conventionally it is given, whether diuretic is being given or not. Then 40 milligrams is the conventional adult dose. After that, sir, the GFR and sir, the T half, basically T half and the intrarenal transit time, sir, that should be our focus. Of course, right. Yes, sir.
So now see the second one below, kidney left and right. Tell us, Abhishek. You tell us now.
Kidney left and right, sir. The perfusion percentage is on the left side. It is 40.44%, and the right side is 59.56%, sir. And I think GFR is 34.5, and on the left side, and 64.37 on the right side. Also, sir, time to peak. Time to peak is a little low on the left side, sir. Of course, it is a reflection of the function of the kidney, sir. That the reduced function of the kidney is causing Yes, sir. So it is a reflection of the function of the kidney. And yes, sir. That is the primary focus in the data that is written over here, sir.
So now, at what GFR you will not do reconstructive surgery?
Less than 10 ml per kg per meters per body weight, body surface area.
Okay.
So
Fine.
differential function less than 15 and
Okay.
GFR less than 10.
Yes, sir.
And papillary thinning of the quarter. These are the.
But that is in the adults. Huh? What about the
Yes.
children? In the children, differential you can go up to even 10 also. Okay. And second thing
Okay,
is,
sir.
even the clinically, some you this is only practical thing I'm saying. There's some pediatric urologists, they say that don't see only this function. Even the patient has got clinical symptoms. That is also sometimes very important. You know.
Yes.
Okay. So this is a report. So next what?
It is this is the usual. Just a minute, sir. This is a usual conception that in case of the child, we will take give some chance. It will improve. So you should be very clear that in a pyeloplasty, near about 40% cases only, 40% cases only, there is improvement in the dilatation. Once dilatation lifelong. It will reduce, but it will not come to zero, like as like a normal kidney. So we will go somewhere, do some sonography. Sonography will write there is hydronephrosis, Curie PUJ, Curie post-operative state. So answer to that is dilatation is for lifelong after pyeloplasty. But there is reduction in the dilatation, definitely. Improvement in the function. If you operate the child within 1 year, there are two, three good papers. One is by Ransley and another is by Dowling. If you operate the child at the age of 6 months, as per the Dowling, and at the age of 1 year, as per the Ransley, there is definitely chances of having an improvement. After that, if you try to do a pyeloplasty, already there is a compensatory hypertrophy of opposite kidney, which prevents the improvement in the function in case of the older children.
Yes.
So infant pyeloplasty vis-a-vis older pyeloplasty or in child pyeloplasty, infant pyeloplasty is more having a chances of improvement of the renal function. And in cases of the adult, chances of improvement is zero. The procedure is done to only to maintain the function and prevent the further deterioration. So these all things should be very clear in your mind, and you should be very clear while talking to the patient.
Yes.
Okay.
Yeah. Fine. So now next what? Nikhil, what you want to do now?
Sir, it's clear, sir, here that this patient is having left-sided PUJ, which is obstructed. So I would like to go ahead and take consent for surgery, sir. For dismembered pyeloplasty would be my surgical choice, sir.
Abhishek, what do you want to do?
So I would counsel the patient and give him various options first, and then proceed as per the patient's.
So how will you proceed? Patient says that you decide, doctor, what is best for me.
Yes, sir. So in that case, sir, I would counsel the patient for surgery on the basis of his CT and nuclear scan finding, renal scan finding. It's a fairly large extrarenal pelvis, sir, and the ureter is in dependent position, sir. So either a dismembered pyeloplasty or a flap pyeloplasty can be done, sir.
What is your choice?
Dismembered would be good, sir, because the pelvis is fairly large. The dismembered pyeloplasty would also help me to reduce the size of the pelvis, sir. The redundant pelvis can be removed in a dismembered pyeloplasty.
Now, do you know what is a CT scan saying?
So there is a renal stone also, sir, for this patient.
There is a
read impression. Read impression.
Stricture in the left upper ureter as described, causing back pressure changes in the form of hydronephrosis and hydroureter as described. right hydronephrosis with non-obstructive right renal calculi. Yes, sir. Sir, there is a left upper ureteric stricture also that is there, sir. So in this case,
what do you like to do first?
sir, characterize the ureteric
So
stricture with
you
the help of
want to take up patient for a surgery. Before that, you like to do something?
Sir, RGP, sir, I would like to do characterize
Yeah.
stricture,
So,
sir.
eyes like a stricture urethra. Here also, upper extent is diagnosed by the CT IVU, and lower extent of the stricture is diagnosed by doing the RGP. That's why each and every cases, two people will do RGP before going for pyeloplasty.
Yes, sir.
In my center also, we routinely do RGP, routinely place guide wire oblique ureteric catheter across or just below the PUJ. It will help in the dissection of the ureter as well as placing the antegrade digestion. So, but it is not mandatory. It is as per your protocol of your institute, you can tell. But these are the things which can be defended in exam.
So, Nikhil, when you like to do RGP, at the time of surgery or before that?
RGP just when the patient is taken in, sir, at the time of the surgery only, sir. First do an RGP and then proceed for surgery.
What is an advantage of doing RGP at the same time?
And RGP at the same time, like in this case, the stricture is for the stricture will get the lower limit of the stricture.
That is number one. What is the second? No, I'm saying why you want to do RGP at the time of surgery? What are the advantages?
So we can plan our operative techniques, sir, on the basis of the extent of the stricture, sir, upper ureteric stricture.
You're not getting my question. The same thing, you do RGP to find out where is the stricture lower limit and you can plan out your surgery. I agree with you. Question is whether you like to do 10 days in advance or you will like to do at the same time when you are going for a surgery. So if you are going to do at the same time of the surgery, what are the advantages?
But it's a functional obstruction, so we will get a clear picture, sir, if it is done at the same time rather than doing it before.
Suppose you have not done a RGP, you have done a pyeloplasty, and the stent is not going from above. It is blocking just proximal to the ureteric hook.
Okay, the VUJ
anatomical roadmap, sir.
Simultaneous. But we routinely don't do, sir, RGP in our center.
And that's what I am telling you. If this happens, what you will do?
Yes. There could be
associated lower ureteric stricture oblique wall oblique ureterostele.
Yes.
And placing the stent antegradely from with these conditions is not easy. Then you have to come out with placing the nephrostomy, again nephrostogram, then next time cystoscopy. So by doing one RGP and one cystoscopy at the time of surgery just before starting for pyeloplasty is not bad idea.
So by doing cystoscopy, RGP, you find out if there is any urethral pathology, if you are missing anything in the bladder and the lower ureteric, sometimes there may be obstruction also. So that also you can find out. And then the stricture. Okay. And the advantage of doing at the time of surgery only is that you are not giving, double anesthesia to the patient. Suppose if you do 15 days earlier. Second thing is, if you do cystoscopy RGP in an obstructed system, there are chances that patient may develop infection, pyelonephritis or pyonephrosis. So that is also avoided. And the third thing is, when you are doing RGP, at that time, as Dr. Gite said, some people put digestant at the same time or guide wire across or ureteric catheter to identify the ureter. So these are the advantages when you do at the time of surgery.
So best answer in the exam, in a case of PUJ is understand hands, open, dismembered, pyeloblast. If the examiner asks you any other way, then considering the configuration and external pelvis and amount of stricture, if it is long, then I can divert or cardinal prince oblique oblique or vertical flap. So it is depend upon the length of the and configuration of the pelvis. Then VI pyeloplasty, if it is high insertion of the PUJ, and VI pyeloplasty. And laparoscopy, if you are doing a routine laparoscopic pyeloplasty, yes, after answering first question with open, and if examiner asks, yes, sir, we are concerned with laparoscopic pyeloplasty, robotic pyeloplasty, and transperitoneal, extraperitoneal. Okay, then transmesocoeli. ये सब चीजें पता रहना चाहिए, लेकिन you should start with open Anderson hands dismembered pyeloplasty.
So Abhishek, now describe this. What is this and what you are seeing?
Sir, this is an RGP image, sir, which is showing, I think the one is pre-op image and the other one is post-op image, sir.
No, both are pre-op image.
One is the
Okay, sir.
In first, on the left-hand side, the ureteric catheter is below the PU junction, and the dye is injected, and you can see.
Yes,
Can you see the upper ureter, which is stenosis and little stitches, whatever is the findings
and there is some amount of dye cut off also, sir, there. And in the other picture, a digestant is passed, and probably there is some decompression of the pelvis that can be seen, sir.
Correct.
Possibly because of the digestant.
Fine. So now what is the next? So what are the which surgery you like to do in this case? You said, nah, you want to do dismember.
Anderson Hines, yes, sir.
What are the principles?
Sir, so the principles of Anderson Hines is that, sir, it is based on sir, the goals of treatment are the goals of surgery are basically funnel shaped pelvis with the inline ureter with the pelvis with a watertight mucosa to mucosa anastomosis.
Just 5 points you tell us. What are the principles?
Mucosa to
mucosa anastomosis.
Yeah, okay. Let Nikhil talk. Okay, Nikhil, tell me.
Sir, mucosa to mucosa anastomosis, watertight, dependent, funnel shape, and
first of all, there is extra renal part. So you want to remove the redundant part of the pelvis.
Reduction. Yes, sir.
Correct?
Yes, sir.
Then,
reduction pyeloplasty.
Then what you want to do? There is a aerodynamic segment of the ureter.
Yes, sir. Excision.
So you want to remove it, and you want to make the opening as big as possible by making it.
By giving a cut onto the ureter and
on the lateral side.
Yes, the lateral side.
Then the most dependent anastomosis, mucosa to mucosa.
Yes.
Correct?
Yes,
watertight.
Watertight.
And tension free.
Tension free. Yes, tension free, funnel shaped, watertight, mucosa to mucosa, and
systematically
the lateral spatulation of the upper ureter.
Yeah, so we said na. So you go systematically removal of the redundant part of the pelvis. Correct?
Yes.
Second thing is to remove the aerodynamic segment and spatulation on the lateral side and make as big as possible. Then you are going to go for anastomosis. So the most dependent, mucosa to mucosa, watertight, tension free. So these are the principles. Suppose if there is a artery in front of PUJ, what do you do?
Sir, in front of the PUJ, we can like when we dismembered it, sir, we can anastomose in front of it, sir, so that it is not getting kinked again. And another thing is that if the pelvis is too big, too large,
you just cut na. You can cut that artery na.
No, sir.
There is one operation of cutting that artery.
Hellstorm's operation, sir.
No, in Hellstorm we don't cut the artery, sir. We just like
wrap
the pelvis around the artery.
And one I am not remembering, but there is one procedure described by just disconnecting the artery. Exactly, I will when I will read and I will tell. I was a procedure.
So can you sacrifice the vein? Can you sacrifice the vein?
What will happen if you cut the vein? If it is vein.
Better not sacrifice, sir. These are segmental vessels, sir. So
vein.
Why vein?
Vein. He's asking about vein.
Accessory can be sacrificed, sir. I feel.
Yeah, you can. Not artery.
Not artery, no, sir. Artery is usually segmental only, sir. So you will not sacrifice the artery, sir.
Why? What
It
are
is
the
usually
reasons?
sir, it is usually a segmental
accessory.
artery supplying the kidney, sir, most commonly. So that's why you cannot, or
So
lower
where
polar
else?
artery.
Lower polar will supply where? Only the lower pole, or where else?
Ureter also.
No, ureter also, sir.
Exactly. So you don't want to sacrifice it, no? Whatever it is. Fine. Okay. So now in this case, just show what other surgeries before I just show you the what we have done. It will just take 2 minutes.
Okay.
Which are the other surgeries and classify and indications?
So if the ureter is like box shaped, like it is a large pelvis, then we can go for Sardino-Prince surgery there. If there is multiple strictures and a long segment, then we can go for a spiral flap surgery there. If the ureter is high insertion, then we can go for PELVI-URETERIC. If it is intrarenal pelvis, then we can go for ureterogallicostomy.
So basically, sir, the indications for doing a surgery may be classified into 3, sir, based on clinical findings, based on ultrasound findings, or based on renal scan findings, sir. So clinically, suppose if the patient is symptomatic, he has fever, pain, has stones, has repeated infections, previous failed surgery, then he is advised surgery, sir. On the basis of ultrasound, if there is a large hydronephrosis with parenchymal thinning or feature suggestive of decreasing deteriorating renal function, then sir we can advise him surgery. So pelvic AP diameter, sir, is large, so then on USG, then and then on the basis of renal scan, sir, if it is showing deteriorating renal function, that is longer time to T-half, lower uptake, sir, and yes, sir, low GFR, then we can advise him surgery, sir. And the various types of surgery maybe, sir, grossly divided into therapeutic and salvage procedures. Therapeutic procedures can be further divided into endopilotomy procedures and operative procedures, sir. So endopilotomy procedures can be antegrade or retrograde, sir. And operative procedures may be, sir, dismembered or non-dismembered pyeloplasty or ureterogallicostomy, sir. So dismembered pyeloplasty is conventionally Anderson-Hines dismembered pyeloplasty, and non-dismembered pyeloplasties may be, sir, Sardino-Prince pyeloplasty, Cultivier spiral flap pyeloplasty, and Foley's VY-plasty, sir. Yes, sir. And salvage procedures, of course, are degestenting and PCN, sir.
And what are the flaps?
Flaps, sir, Sardino-Prince vertical flaps, sir, Cultivier spiral flaps, sir, Foley's VY-plasty, sir.
So when you will do this?
Sir, Sardino-Prince vertical flap is done when there's a large box-shaped pelvis, sir. In that case, sir, we should do a Sardino-Prince, a spiral.
Abhishek,
sir.
Sardino-Prince is the vertical flap.
Yes, sir.
One. Another thing is fuses should be already dependent. That is requirement.
Yes.
Then it will provide less length than the spiral.
Right, sir.
And contraindication is high insertion of dural.
High insertion. Similarly, sir,
Gulp divert is better in adult and for long length stricture. It is a spiral flap.
Yes.
So length to width ratio is 3:1. And the UPG angle is more than 90 degrees, should be more than 90 degrees.
Obtuse.
Otherwise, because you are taking a spiral flap and it bringing it down. To augment,
yes.
It is like augmentation uretroplasty. So to augment the ureter. Then another is Davis intubated ureterostomy is one of the treatment for this. Then endopilotomy, already you told, it is 77 to 85% success rate, primary endopilotomy, secondary endopilotomy. There are various indications of primary as well as secondary. Ureterogallicostomy is usually a last resort. It should not be considered primarily. Still, literature supports in some specific situation primary ureterogallicostomy, but what I feel is it should be a last resort when your all other options are failed.
Intrarenal pelvis.
Intrarenal pelvis. If it is a totally intrarenal pelvis, and if you don't know any other option, okay, I agree. But such situations occurs very rarely. Then ureterocalacostomy, salvage procedure again if the post ureterocalacostomy, post pyeloplasty, big strictures. In such situation again, you have to do that particular segment Yang-Monty ureteric replacement. These are again one of the salvage procedures. Whole of the upper ureter is suppose stricture. Skeleton, someone has done a skeletonization, whole segment is gone. In such situation, again we have to replace the ureter with ileum. Last resort is auto transplantation. उसके बाद में last is nephrectomy. So it start from nephrectomy, auto transplantation, ileal ureter replacement with ileum in terms of Yang-Monty or total or appendicular replacement. Then if it is stricture with BMJ and inlay or onlay, nowadays people are doing for some particular upper ureteric strictures, and all the procedures described for PUG is that again you told dismembered, then flap and vendopalapa. So this all should be in the armamentarium while doing the PUJ patient, because patient may presented with, just I have done in last week, there also know the 2 pyeloplasty failed. And there is a big stricture. So done ureterocalacostomy.
Okay.
So it is as per the requirement. What in this particular patient, you have to again keep watch on that stone. That stone should be removed. Then situations where someone has primary digestion, the primary stopgap arrangement, primary PCN, primary digestion. There are some specific indications. Suppose patient had an infected hydronephrosis, patient had a reasonable TL, patient had a fever, patient had a local tenderness. So as per the internal glucose, amount of internal glucose, you have to divert this patient internally or externally. And use that after 4 to 6 weeks of the drainage. If you have placed the PCN, use that PCN to assess the renal function also by doing the specific ground osmolarity output. If you have placed a digestion, then again go for the scan, DTP scan. So these are the bilateral PUJ with renal failure. Again, there is role of diversion. So these are the indications for diversion, primary diversion. मेरे ख्याल से प्रोसीजर तो हमने बता दिया ना सर, प्रोसीजर बोल दिया क्या उन्होंने? Have you told the procedure?
Not yet, sir.
So in short, you should at least know the steps of the pyeloplasty. Anyone can tell. निखिल और अभिषेक, दोनों में से कोई भी एक जन बोलो, कोई प्रॉब्लम. Just step.
So, sir, for pyeloplasty, we usually, sir, the approaches can be different. Usually, in our center, sir, retroperitoneal pyeloplasty is preferred, sir. So the patient is taken in flank position and flank incision is taken. The pelvis is approached, sir, and sir, after approaching the pelvis, it's actually the ureter is traced, sir, and then ureter is traced and up to the pelvis, and then, sir, the pelvis is approached that way, and then thereafter, sir, stay sutures are taken on the distal part of the ureter, which is just distal to the stricture and the pelvis, sir, redundant pelvis. And after that, sir, with the help of those stay sutures, sir, the adynamic segment of the pelvis is removed, sir. And the approach which we have planned, we take, sir, like reconstructive approach. And sir, the reconstruction in our center is usually done with the 40 PDS, sir. 30 PDS, sir, and interrupted sutures are taken, sir. Continuous can be taken also, sir, but it is all on the surgeon's preference, sir. And then DJ stent is placed also, sir. DJ stent is placed, and over that, sir, suturing is done with PDS, and drain is placed, sir. Drain is placed, and the wound is closed, sir. And then after that, sir, sir, either the drain or the Foley's can be removed earlier, sir. But in our center, sir, we remove the Foley's first, and then after that, if the next day the drain is very less, if the drain is negligible, then the drain is removed, sir, and the digestant is removed after 6 weeks. And after that, after 6 weeks of removal of digestants, means total 12 weeks. After that, we do a repeat nuclear scan to assess the improvement of function of the kidney, sir. Ultrasound and this thing, sir, renal scan, sir.
Try to add one line. Avoid skeletonization of ureter
Yes,
and
sir.
dissection in the
Yes.
golden triangle,
Yes, sir.
because that is important.
Yes, sir.
If you skeletonize the ureter, how good
Yes.
you do a pyeloplastic will going to.
Won't take. Yes,
So
sir.
this and complete hemostasis. These two
Yes,
things.
sir. Yes, sir.
Okay. Then indication of nephrectomy.
Sir, indication of
For one is this thing, sir, the function of the kidney.
Doctor,
Is one.
1 second. Gite sir, I will just show them the steps that
Okay.
there are there.
No
just
problem.
yeah. No. First, yeah. Just zoom it.
Yes.
The first one. The left one. Yeah. The left one. Yeah. So here, can you see? The infant feeding tube is all around the left one. The first one, yes. That zoom one. That, yeah, zoom that.
Yes.
Yeah. Can you see pelvi-ureteric junction, pelvis,
Yes.
triangle pelvis,
Yes,
and
sir.
the ureter, and then you can see the infant feeding tube. So what we do is we put the 5-0 black silk medial and lateral aspect of ureter as well as on the pelvis. Okay, the right one, second one. Can you see the digestant inside? Can you see
Yes,
the
sir.
black?
Yes, sir.
Correct, medially and laterally.
Yes.
Okay, and we have opened up the
Pelvis.
pelvis. Okay, next. Can you see all 4 threads?
Yes, sir.
Yes, sir.
Right? And this is the after the anastomosis.
After
Okay.
anastomosis. Yes,
Okay,
sir.
next one, Achin.
Yes.
Only these 3 you have got it?
Only these pictures are there. One more I
Okay.
have. This is the anastomy.
Yeah, see, there's a posterior anastomosis is done, and now we are
Yes, the
doing
anterior.
Anterior wall.
when the ureter and all I have not sent you. The
Yes,
cut.
sir, it's there.
See, this is there. That is what I want. See, left side you zoom it. Can you see?
Yes.
The ureter is petrolated on the lateral side, and the
Yes, sir.
redundant part of the pelvis. Can you see that I have kept it so
Yes.
that we can hold it with a forceps. Okay,
Yes.
and after that, show the right one, Achin. Yeah. Okay. See, the pelvis is opened up. The right one. The third one, right one. No, that's okay. Fine. Okay, so these are the steps. Okay, Dr. Gite, you can go ahead. Dr. Gite,
Sir. आवाज आ
you
रहा है?
can go ahead. Do you want? Can I show them one more case? Just 5 minutes, and then you can go on a discussion because that is a little different. Okay, Achin.
Vivek is also ready with
Yes, sir.
one case.
So we have different other scenarios also.
So Vivek is also ready with one case if you want to.
Okay. So Achin, just show this case very rapidly.
The other case, sir.
Yeah, second case.
So the child, sir. Sir,
You
Muslim
go
by
very
5
fast.
Muslim by 5 years of age, essentially the same complaint, left loin pain since 2 months. Mostly the characteristics same only. And he also doesn't have any posterior history, specifically antenatal history has been asked since he's a boy, a young boy. And examination, this is the examination.
Anyone can comment. Nikhil, you want
Yes,
to
sir.
say something about?
Yes, sir. There is a swelling seen onto the left side of the abdomen, sir. And apart from the genitalia, everything looks normal, sir. There's a gross swelling, sir. There's a big swelling which is crossing the midline.
Yeah,
It's like
that's
a giant, yes, a giant hydronephrosis. It looks.
Yeah. Okay, Achin, show the investigations. Yeah, this is the X-ray. Just show the X-ray. First, just show them the X-ray. Can you see? You can make out the intestines. Everything is just pushed on the right hand side.
Yes, sir.
Yes, sir. Yes, sir. Yes.
Yeah.
Big.
Yes, sir. Yes, sir. Big.
Even the descending column is pushed. Okay.
So here discussion will be on giant hydronephrosis.
Yes. More than 1 liter of.
More than 1 liter crossing the midline.
Yes.
Yeah.
Midline.
You should know the definition of giant hydronephrosis.
Yes.
Okay, one of you can just pass. You can comment on the CT scan.
There is a non-enhanced CT scan, sir, showing.
Non-enhanced.
Oh, how come it is opposite kidney is contrast is there, no?
I can't. Okay, I'm seeing this thing, the left side film. I was seeing the right side. The right side one is the contrast. It's an excreted film that is seen onto the right side.
And the right side, you can see the contrast in the rim. Just
yes, sir. Yes, contrast in the rim. It's a excretory film, sir. Billet phase, and contrast is there on the rim, sir. Almost very thinned out cortex, sir, with rim enhancement, sir. And a large hydronephrosis is seen, sir. Very large.
It is extension is right up to
the
diaphragm.
Below, sir, it is crossing the pelvic. This is the bifurcation. Almost up to the
Yeah. Okay, fine. Just show the next investigation. Achin?
Answer.
Yeah. One of you did
yes, sir. In this DTK phase, the uptake is good, sir, in the perfusion. And in the excretory films, we can see the right kidney excreting, also left kidney, there is no excretion, sir. It is a flat line, very low. It is seen, and diuretic half also for left side is 1.75 and 8.5. And in the films, we can only see the right side kidney holding up, left side kidney.
There is complete photopenia, sir, on the images.
What is GFR and what is the differential?
GFR of this. This is an EC scan.
It is GRP.
Effective renal.
Calculate the GFR by dividing it with 21 divided by how much? GRPF is converted to GFR by dividing
4.
Tell us.
How much is the GFR? Abhishek, if ERPF is suppose 90, how much will be the GFR?
Sir, I'm not aware how to calculate, sir.
Divided by, we usually divided by 3.
Okay, sir.
So someone has written in the chat it is 4. So what I have read is we divide it with 3, and whatever the number will come, it will be the real GFR.
Okay, so the left kidney GFR is 7, sir.
7. Yes, that means that kidney is gone.
Gone, sir.
Yes, sir.
Okay.
So what do you like to do in this case?
Sir, it's 7 this thing, and age also is 5-year age, sir. So we can go ahead for a nephrectomy, sir, onto the left side.
Would you like to do PCN on this patient?
If the patient is having fever or anything like that, we can
No,
do PCN.
PCN just to find out whether that is a functioning kidney or not functioning kidney. What are the purposes of doing PCN in PU junction obstruction?
Sir, one is if the patient is having any sepsis like pyonephrosis or anything, they have to relieve that. Second thing is the function also, sir, like spot sodium we can get, and osmolality and pH. Sir. So this thing, but already here DTP is giving us the EC is already giving us this one, sir.
Nikhil,
No, but still,
if the examiner has asked the question like that, so it is daily volume, oblique output.
Yes, sir, output of the daily output.
Color of the urine.
Correct.
Specific gravity of the urine.
Yes.
And urinary sodium, pH,
yes.
and chloride.
Yes.
That and osmolarity.
Osmolarity.
Okay. So assessment of the function, assessment of the daily output. Suppose output is 400. Does it mean that it is urine only? It may not. It is just water. So concentrating ability of the kidney is lost or not to be checked. Okay. So this is one way of assessing the function of the kidney in equivocal cases by doing the PCN oblique DJ. Suppose initial days, people used to place DJ for pain. If pain gone, that means there is obstruction. These are the indirect ways. Whitaker test. Nowadays, no one is doing, but Whitaker test is another way of doing equivocal assessment of equivocal PU.
Yes.
So PCN, Whitaker test, DJ, these all things are nowadays absolute, but still few people is doing it. Sometimes patient don't want nephrectomy. I don't want nephrectomy.
Okay.
So in such situation, give one chance, place the DJ oblique patient, assess the renal function, let patient beg for operation. Don't force any operation to the patient.
Okay.
He should tell कि नहीं सर अभी बहुत हो गया अभी निकाल.
Okay, so now in this case, what do you like to do?
In this case, we will explain to the patient, sir, like the poor functioning of the kidney, we will explain to him, and then as sir is telling, we'll give a choice
to the patient. 1 second, Nikhil, you will explain this to the patient.
Parents, sir.
The parents, because
parents.
Yes, sir, yes, to the parents.
Parents, yes.
See, in exam, you are not giving a theory exam. So in this case, you have to talk in relevant to this patient. Fine. Okay, so you'll talk to the parents and you will explain them everything. Correct?
Yes.
Then you'll go ahead. So what do you like to do?
So this thing, I would like to give them an option for this thing, sir, like nephrectomy. And if they're not willing for nephrectomy, then we can give them a second chance, like placing PCN and then seeing the output and then monitoring. That will give an additive feature. Like if even the PCN patient on PCN also having the same adverse features, then
Nikhil, in exam, this is not the answer. In exam, size of the kidney, particle thickness of the kidney, differential function of the kidney, then GFR of the kidney, age of the patient. Considering this factor, I will go for nephrectomy. If examiner says the patient don't want nephrectomy, then in other way, कुछ कर सकते हैं क्या? Sir, ideally it should be considered for nephrectomy, but then whatever you are telling.
Okay.
So what type of nephrectomy you like to do? Open or laparoscopy?
Sir, we do open on this.
Why open? Why not laparoscopy?
Sir, we don't do actually pediatric cases, sir. Much.
No. Nikhil, again, the answering this question is very tricky. Sir, at our center, we usually do open nephrectomy, but in a center where it is possible and have experienced hand, laparoscopic oblique robotic nephrectomy is better than open nephrectomy in such situation. Let the examiner will be happy, and that is the reality, na?
Yes, sir.
So, laparoscopic nephrectomy versus robotic nephrectomy versus open nephrectomy. Open nephrectomy is third. तो उसमें कोई एक्सेप्ट करने में कोई दो राय नहीं.
Here, na, you can see it is crossing the midline. It
Yes.
is in Bachus. Again, it is so difficult to now put the pots. Where you will put it?
Yes, sir.
If you put it, you will directly enter into the kidney, pelvis only, na?
Yes.
So here, and in the picture, so it becomes very difficult. So here, the answer is open. Okay?
Yes.
Okay.
So
So, Abhishek,
huge kidney is there. If there is no place, okay, where you will put it?
Yes, sir.
so port placement is difficult.
Hmm.
But some expert examiner, expert laparoscopist or robotic person, he can just decompress the system and some place here and there, and he will go in and some dissect. So करना है कोई तो कर सकता है, उसमें कोई दो राय नहीं है. लेकिन ideal answer, what you are doing at your place, that should be the first. And I as a resident just appearing for the exam, open surgery exam में बोले वाला कभी भी. Let them check in laparoscopy, तुम बता दो. So what is the physiology of normal PUJ?
Sir, the pacemaker cells of PUJ are of the pacemaker cells of the pelvic ileal system are present on the PUJ, sir. And from there on, sir, the urine bolus is propagated into the upper ureter, from wherein the urine bolus is moved further into the ureter by the combined action of the spiral and the longitudinal muscles of the ureter, sir.
Exactly. At rest, the PUJ is closed. That is the first. Another thing, normal resting pressure of the PUJ is 0 to 5 centimeter of water.
5 centimeters of water.
Frequency of peristalsis starts from the which place? Peristalsis starts from which place?
9.
That whatever your pacemaker cells कहाँ पे रहते? Leave it. Frequency of peristalsis is 2 to 6 per minute. Okay. When the urine bolus is formed, that bolus is act like a pressure wave. Okay. And that segmental peristalsis start from the minor calyx, transmitted that wave to the pelvis, compresses the pelvis, pushes that bolus in front. Again, it will disappear. Another frequency, another peristaltic wave come. Again, it will push down, down, and down. So this is the normal physiology at PUJ.
Yes.
So follow up of the patient, pyeloplasty.
So post pyeloplasty, we'll follow the patient. Where first thing is that about the drain and Foley catheter removal. So in 48 hours we remove the Foley catheter, and after removal of Foley catheter in 24 hours we can remove the drains for the patient, and DJ stent is removed in 6 weeks. And after 6 weeks we'll do the first scan for the patient in 3 months. So after 3 months, with ultrasound KE we will do.
With history, clinical examination,
With history, yes.
ultrasound of the KE.
Abdomen. KE.
And what you will check in that ultrasound?
So we'll check for things that hydronephrosis, whether it is present.
Size of the kidney preoperatively, size of the kidney postoperatively, amount of hydronephrosis preoperatively, amount of hydronephrosis postoperatively, any cortical thickness change.
Yes.
Okay.
Yes.
Then
Next again we scan the patient at 3 months, sir, and we check the patient. And this time we assess the patient, sir. So before branding any patient as whether the pyeloplasty is successful or failure, we have to take at least 6 months to 12 months time, sir. Before that, we should not brand, because that is
the late recurrences occur as late as 3 years also, sir. So at least 2 to 3 years follow-up should
as per the old guidelines, follow-up should be up to 2 years.
2 years.
So 3 monthly sonography, 6 monthly, 3 months, 6 months, and 3 monthly sonography at 3 months, and 6 monthly for 2 years, and 1 yearly DTPA for 2 years. This is the follow-up what I have read while my training. But nowadays, DTPA, doing a DTPA up to 2 years is not required. So one DTPA, if it is non-obstructive, at the end of some people will say it is 3 months, some people say 6 months, but at least it should be 1 year.
6 weeks after the removal of DJ, sir, DTPA is done in our centers.
Yes. Yeah, some centers were doing the DTPA at 3 months, and if it is normal, they are labeling it as a normal, successful pilot.
Successful pilot.
Yes.
But as there are concept of delayed recurrence are there, what we were doing at our center is sonography at 3 months, 6 months and 1 year, and DTPA at 1 year and 2 years. Conventional follow-up for 2 years.
Yes. Maximum failure occurs within 1 year. After 2 years, it's rare to.
So, sir, विवेक को co-host बनाते हैं, एक short case
Co-host, yeah, विवेक
10 मिनट का है, उसके बाद में फिनिश कर देंगे, कुछ क्वेश्चन है तो आंसर कर देंगे।
राकेश जी, make Mr. Dr. Vivek co-host.
Achin, you can just, yeah.
Vivek is a co-host now, sir.
Yeah, Vivek, you can just show.
विवेक, hello.
Yeah, Vivek, you can share.
You have to click on share screen option at the below of the screen.
विवेक है या चला गया? म्यूट कर दिया सर उसने।
Okay. Next time we can show it then.
Sir, am I audible, sir?
Yeah.
Yes, Vivek. Okay, now share the.
Yes, sir. I'm trying to share it.
There is a green icon. Click share screen.
Yeah.
Then we can see your screen. Then you can present whatever you feel like presenting.
I just want. Just wait a minute.
Sure. Yes, you can see your screen.
You can see my screen.
Yeah, I can see you have opened that Zoom meeting. Yes, I can see your desktop screen. Yeah, you have opened the PowerPoint. Yes. Oh.
Vivek, don't go in detail. Just complain, investigation,
Yes.
and treatment.
Yes, sir. Sir, our case was a good evening, everybody. First of all, sir, our case was a 16 years old male patient who was a resident of Kurla and who presented to us with chief complaint of right flank pain for the last 2 to 3 months. Patient did not have any history of fever, hematuria, lithuria, no comorbidities, no significant family history. But he had significant past history of right-sided open pyeloplasty done at outside setting in 2018. And again, a right pyeloplasty was done in April 21, followed by removal of the right DJ stent in August 21. So the details of which is given later, sir. On examination, nothing significant. Per-abdominal examination, previous scar mark was there with the right-sided minimal flank tenderness was there. Palpation was normal and all the systems were normal. Investigation, sir, urine routine was normal. All lab investigation, including creatinine, was 0.8. It was normal, sir. So the DTPA scan, we did not have any prior ultrasonography or CT scan of the patient. He just came with to us with DTPA scan. So in 2018, when first right pyeloplasty was done, his pre-op GFR was 48.3 of the right side and left kidney was 63. After the OT, in the post-op period, his GFR of the right kidney was 49.5 and it was unobstructed in 2018. Then in 2021, the patient developed symptom and in March 2021, he was evaluated again with a DTPA scan where the pre-op GFR of the right kidney was 25.9 ml. Left kidney was
Vivek,
Vivek is offline, sir. He's suddenly gone offline.
I think his Wi-Fi is not stable.
He's offline, sir.
He got muted, probably.
No, he left. No?
He himself is a co-host, sir. He can unmute himself, but he suddenly his Wi-Fi must have stopped. Sir, we have one more case scenario.
I think we can conclude it if he is not able to get it.
Okay. Whenever he join, he can just show the pictures. I will just tell the history. This patient underwent twice pyeloplasty in the past with on same side. Both time it is open. In between, within 1 year, he is again symptomatic. Second time pyeloplasty. Both time surgeon doesn't found any luminal narrowing except king. So first pyeloplasty, second time RGP, there is king. The ureter is going and attach, it is stuck to the lower pole of the kidney and coming down. Second time again, same finding. So second time also patient symptomatic, pain, fever. Third time he come to us. We have done a CT scan, and there is a gross hydronephrosis on right side. With cortex is not too good on both the polar side as well as in mid pole. So patient and primary surgeon don't want kidney to be removed. So considering the baseline renal function is in spite of having not too good, we have done ureterocalcostommy. Vivek?
Sir,
Yes.
sir, I'm sharing my screen, sir. I'm sorry.
Directly to investigate.
Yeah, sir. A CT scan was done. Sir, I would like to show the CT. Sir, there was right-sided gross hydronephrosis with severe paper thinning of parenchyma. The upper pole thickness was 7 mm, mid pole parenchymal thickness 6 mm, and lower pole was just 5 mm, 4 mm.
Next.
This is a plain coronal section. This is a delayed section, sir. There was evidence of pooling of contrast, and
If you see these images, there is a uptake as well as excretion of the contrast inside the pelvic. The contrast is there. Contrast uptake is there. Contrast excretion is there. But excretion across the PUJ is not there.
Yeah.
So that means the kidney is functioning. How much it is functioning, we will say on DTP. But amount of hydronephrosis, it is too high.
Yes.
Gross hydronephrosis. Next.
This was the cortical thickness that was shown around 4 mm for the lower pole, where we did our anastomosis. So we did a right-sided RGP with right open ureterocalcectomy. This was the immediate pre-op RGP that was done.
So there is a approximately 1 vertebra distance at the level of PUJ. The contrast is going like a jet, and there is a cross hydronephrosis. Next.
Intraoperatively, we would like to play.
So this is very important. If you have not dissected the lower pole all around completely, and the distance between the cut end of ureter and the lower pole, it should reach each other without any tension. So this is what that video is showing. The lower pole is going right up to the
this is about the spallation.
Yeah, cut end of the ureter, and this is a spatulation. So in ureterocalcectomy, play karo na.
Spatulation of the ureter on the lateral aspect shown by sir.
It should be on the lateral aspect. उसका वीडियो है? विवेक वीडियो है क्या?
वीडियो करो, क्लिक करो. विवेक.
He's again offline, it seems.
ठीक है. leave it.
Okay.
लास्ट 2 फिगर्स में बाद में दिखाने की
सर आ गया सर, एक सेकंड
बोलो, जल्दी जल्दी बताओ,
जी जी
टाइम खत्म मत करो।
सर, ये दिख रहा है?
Yes, yes, we can see.
Make it
Please
zoom.
put it on slideshow.
Yeah, definitely.
So, क्या कर रहे हैं? As far as the ureterocolectomy is concerned, there are 2 ways of doing the ureterocolectomy. One is the coring and another is gluten. So, when there is a amount of cortex is too much, cortex is too good, in such situation, if you done a coring, then chances of getting a restructure after doing ureterocolectomy also is more. So, coring is not good. Gluten is better than the coring. Few people were doing the ureterocolectomy on lateral aspect of the lower pole. But what I feel personally, it's a dependent. It should be dependent. It should be easy for any intervention required in future. That means the calyceal long axis and ureter long axis should be in one line. These 2 things cannot be possible when you are doing a ureterocolectomy on lateral side. So best way is to just do a gluten, use the gluten technique, cut the lower end, then invert some amount of capsule, then resect the kidney approximately 2 to 3 millimeter like a gluten amputation. Then hemostasis, sphincter should be fixed with transfixed with figure of 8 sutures, and then lateral spatulation and ureterocalyceal anastomosis to be covered with the capsule as well as surrounding fat. If fat is not available, the momentum can be brought from peritoneal side to retroperitoneal side and covered it. And the fixation of the kidney, if it is not fixed. If this kidney is already operated twice, it is already fixed, so we have not fixed the kidney. Just place the nephrostomy from the middle calyx. So ureterocalyceal anastomosis over the resistant with midpolar PCN and end-to-end dependent anastomosis. It should be dependent. That's what. And the cutting of kidney, if you zoom it, you should see it should be wide open.
Just zoom it.
Vivek, you can right click on the presentation.
Yes, sir. This was the opening of the lower pole.
Okay.
See this picture. This much kidney should open.
Okay, fine. Okay,
Otherwise,
show it on the right hand side. Yeah. Scroll it on the right hand side. Yes.
Yes, sir. Yes, sir.
Second thing, yes. Zoom it. Okay.
You do one thing, you put it on slideshow mode.
वो इमरजेंसी में बनाया उसने, तो थोड़ा सा गड़बड़ हो गया.
अभी you can right click.
Yes. Just give me a sec.
You can right click and zoom in, and you can just go onto the thing you want to zoom in.
This is after the completion of the surgery, covered by the anastomosis is well covered by the fat.
Very nice, see that. Just later on, after some time, just when you do repeat RGP, just let us know. RGP
Yes,
or DPPS.
Yes. Already there is a one for students. Already there is one paper about the ureterocolectomy in Brazilian Journal of Urology by myself only. Case of 5. There are 5 cases case series. So all cases one includes one redo ureterocolectomy in that series also, plus this 2. So just important thing why I have shown this case is, if you are planning for ureterocolectomy, 2 important things. There is always not necessary to control the vessel, number 1. Number 2, mobilization of lower pole or around is a mandatory. Number 3, mobilization it should reach up to the cut end of the ureter. Number 4, spatulation of ureter is on left side. Anastomosis should be stented, and PCN should be placed proximal to the calyx of anastomosis.
Okay.
That is what my experience.
Very good. Fantastic. Excellent, sir.
Okay, sir. Anything again? कुछ
No,
add
I
करना?
think Yeah, we have completed today in detail.
Any
So-
questions regarding PUJ? Please let us know. On अभी पूछना है तो अभी पूछो, पता है तो अभी बताएंगे, नहीं है तो पढ़ के बताएंगे.
Yeah.
Sir, sir, I have one doubt, sir. Can I ask?
Yeah, please.
Go ahead.
Sir, this thing, sir, during our presentations also it is asked, is it mandatory that we have to do a CT scan, sir? Because all the information we are getting in ultrasound also. Can we directly go for DTPS when the suspicion is strong?
Sir.
In child, I already answered this question. In child, no one is doing the CT scan, considering the radiation.
Yes.
Okay, so people who are doing ultrasonography in pediatric PUJ, ultrasound and DTPS scan is sufficient for diagnosis.
Yes.
Plus minus doing a RGP cystoscopy at the time of surgery. It is depend upon the your routine protocol. In pediatric, we usually do a cystoscopy RGP to assess the length of the structure, because we don't have anatomical roadmap in terms of contrast. In adult, why we are doing the CT IVP? I already told. Vascular map, anatomical roadmap, functional assessment, and parent configuration of the pelvis. This is why we were configuration of pelvis, parenchymal thickness, and all the things which is to be seen in the sonography is confirmed by the CT. If you want to have only sonography, then you should have Doppler. One, crossing vessel technique. Second, length of the structure. Intraluminal assessment of the PUJ site as well as ureter site is always better with the contrast study than the sonography. Indirect assessment is possible with sonography, like amount of hydronephrosis, up to hydronephrosis points of place, then sudden cut off, that can be seen on the sonography. But contrast is going, is the luminance patent or not? Contrast is going down or not? Is that at that particular time, so while doing the sonography, if there is suppose peristaltic wave? So these things, anatomical roadmap got on the CTIVP, and anatomical information get on the Doppler plus ultrasound. What you will prefer?
CT.
Suppose, and your answer is over there.
So in adults, we always do CT. Okay?
Yes. Sir, one more this thing, sir. It is always asked in a case of failed pyeloplasty, sir, which is next best option, sir? Like endopylotomy we have to answer, or we can answer pyeloplasty only, sir?
Again, so deciding the type of procedure. Failed pyeloplasty means what? Suppose the person who has, the case what I have shown, the person who has done a twice pyeloplasty, still the amount of PUJ seen extrarenal is adequate. But that area got cicatrized, and the amount of ureter cicatrized trapped inside that cicatrized area is length of approximately more than one vertebra. So in spite of dissecting there and doing a tensionful anastomosis, I have planned for ureter. Suppose after doing a pyeloplasty on CT or RGP, if the amount of pelvis is outside the kidney is adequate, length of the structure is minimum, just you dissect that area and do a primary, again, Anderson-Hans pyeloplasty. That is one. Another thing, if the length of the structure is too high, so the length is too much, then either you go for ureterocolectomy, or if it is not possible, length again small, and if you don't want to dissect, and if you want to give a chance by doing two endopylotomy. So it is depend upon configuration of the pelvis. It is depend upon the amount of structure and length of the structure.
Okay.
Anything else?
Sir, one last question, sir. We never stent the patient, sir, in doing this pyeloplasty, because our sir says that the hydronephrosis comes down if you stent, and it is difficult in intraoperative to identify the area. Sir, how do we like you are regularly stenting and doing
you don't do stented anastomosis?
During surgery, sir, when we open that ballooned out pelvis will be lost, is what we have been taught, like that.
What we are also doing is we are keeping the ureteric catheter just below the PUJ, so that it should not get decompressed. But it will help in dissecting the ureter. It will help in identifying the ureter. It will help in placing If it will help in placing the DG antegradally by passing the guide wire across that ureteric catheter intraoperatively. Over that guide wire, you have to just place the digestion. I have operated a number of patients after pyeloplasty done by general surgeon. Stent is in the ureter only. Not going. And you have to go to a cystoscopy, do a ureteroscopy, pull that stent, again pass the guide wire. Why to unnecessarily take a chance? And you are that distal to PUG.
Distal to PUG. Thanks. Thank you.
Okay. I think we'll close it down. Thank you very much to all of you. Okay.
Thank you, sir. Thank you, Gaurang Shah, sir. Thank you, Gite, sir.
Next time we are doing, so I want one of you to volunteer for one of the topic for 10 minutes presentation. Abhishek, if no one is ready, if you can make some 10 minute presentation on a topic, I'll just give it to you. Is it okay?
Okay, sir.
Okay. Then I'll send to you. Okay.
Right,
fine.
Sir.
Okay, thanks.
Thank you.
Thank you, sir. Thank you, Sodha, sir.
Good night, everybody.